Hi everyone, my name is Wal Hussain. I'm a consultant dermatologist and lead for skin cancer and teledermatology here at Chapel Allerton Hospital. It's been about 3 months since we launched the teledermatology service, so we thought it would be a good idea just to give everybody an update as to about where we are so far in the process. The first thing I'd like to say is a huge thank you to all practices, practice managers and all staff in GP practices out there that are really engaged in a fantastic fashion up and across Leeds. We realise with any new process it takes a bit of time to embed and get used to a new system, but we're really impressed by the level of engagement. We're very grateful and we're hoping that the service can just get better and better with time. We fully appreciate the hurdles that there have been to implementing the system, and we're hoping with a regular dialogue between primary and secondary care we can make the system as slick and as user-friendly as possible. What's really interesting is that we've had a huge amount of interest up and down the country from other CCGs, other secondary care providers from Scotland all the way down to Cornwall about how we're running this service, and so we really are leading the way in advancing skin cancer care for our patients here in Leeds. So a huge thank you to everyone. As with any new system, when you launch it, there's a few hiccups along the way, and the teledermatology steering group is monitoring how the service is working. Every fortnight we meet up and we identify where there's potential problems and where there's areas where we can improve the actual pathway. So the first thing is just a reminder that all dermatology referrals for suspected skin cancer should now be referred via the RAS pathway, and that's really important. I'd encourage everybody to use the new updated forms, which should all be available to you. In terms of the actual protocol for the teledermatology service, again, just as a reminder that each individual lesion requires 3 pictures to be associated with it. That's the locator, i.e. find out where on the body it is, the arm, the leg, etc. A close-up of the lesion, the macro as we refer to, and then the dermoscopy, and that's where you use a special device to provide a close-up identification of the growth itself. So just a reminder that we need 3 images per referral: the locator, the macro, and the close-up dermoscopy. The biggest obstacle we've found so far in making accurate clinical diagnosis is the quality of the images that are coming through. We know from previous data that if we receive good quality images that we can diagnose skin cancer and benign lesions with great accuracy. The difficulty that we're having at the moment is that a lot of the pictures are actually out of focus, and what that means is that we are unable to make a clinical diagnosis based on that image. And what that's meaning is that we are actually seeing more referrals having to come to hospital simply based on the nature of the image rather than the lesion itself being suspicious. I know it's a new system, new technology, takes a bit of time to getting used to, but that at the moment is our biggest hurdle. We've regularly been auditing the number of patients coming through whereby the box has been ticked where there are more than 1 lesion which is suspicious for melanoma or squamous cell carcinoma. Now in clinical practice we expect this to be a very small percentage of patients, but what we're finding is that this box is being ticked, but actually the patient only has 1 lesion to assess. So we would encourage you to please fill out that form accurately, because it does allow us to triage the patients in the most effective manner. As you're all aware, one of the aims of the teledermatology service is to expand that to beyond 2-week wait referrals to general advice and guidance, and allow patients to be seen and triaged directly, for example, for procedures. At the moment, we are getting a disproportionate number of high referrals, again, whereby we're being asked to look at a general skin check or undertake a general skin check, which is clearly not the aim of a 2-week wait referral pathway. My strong advice would be that if you're worried about a patient's general skin and you want them to have a general skin check, that they be referred via an appropriate alternative pathway, not the suspected skin cancer pathway. All in all, the pathway is working very well. The key messages really are that we in secondary care are reliant upon good quality images in order to give you an accurate opinion. We're obviously welcoming any feedback whatsoever. If there's anything that we can do to make the system better for you, for our patients, for the entire service, please do feedback to us. But once again, I'd like to thank you for your engagement and your ongoing support.